Good
Hey,
morning. We're going
Jess.
to give it a few minutes. I'm going to run to the restroom really quick.
Hey, Jen. Hi, good morning. Hey, I have no heat and no hot water, and I've got the folks headed out. They'll be here in about 30 minutes. So I'm just going to keep
Okay.
my camera off because instead of being in my office, I've got to be down here at the kitchen table. And if they are clunking around, so I'm just going to keep it off, but I'm here and I'll chime in.
Okay, sounds good. Thank you.
Sure. All right, lost my screen somehow. Okay, Jen, I'm ready whenever you are.
Let's get started. Happy Monday. Let's see. We have 1, 2, 3, 4, 5, 6, 7. So we have a quorum. Do I count 7?
I'm counting 9, but it like also moved halfway through my count. So, let's see here. 1, 2, 3.
Perfect. Either way, we have a quorum.
Sweet.
All right. So if we want to review February minutes,
If I go too fast, or you want me to scroll back up, please just say something.
perfect speed. Any amendments to January, February minutes? Questions, additions?
I don't know that this is Michelle. Hey, I don't know the DOC folks. I know it says Michelle invited. Can you just amend that to say Michelle suggested inviting? Because I know, Jess, you were the one who had them all, I think, in your address list.
It actually wasn't me.
That was
Oh,
me.
That
oh,
was
it was
Jen.
Jen.
Okay, we can.
Fantastic. Yeah, just
So then we'll say Jen did it.
Jen did it.
I had a separate meeting with them.
Oh, how'd it go?
It was good. They had reached out trying to figure out how to get somebody into the state hospital, and then that led to a further discussion about mental health treatment for patients discharging from DOC. And so I thought that maybe it would be a good idea to invite them to have a larger discussion.
Nice.
Very nice. All right. So here is the current agenda for today.
Agenda review, minute approvals, inpatient discussions update.
Any changes to the agenda really quick, or anybody want to add anything before we move on? Cool. I'm gonna actually stop sharing my screen, and then when we need the agenda, I'll bring it back up. Okay, inpatient discussions update. I was able to get with my team a couple weeks ago and kind of just discuss that list of questions that we had all compiled that we were wanting inpatient hospital providers to join us in. It is now pushed back to May. And the reason it's pushed back to May is that way we'll get more providers instead of our in-person in April. Excuse me. That was after discussing with my team and their recommendation that that option be available to them virtually, just because we have several providers like in Colorado Springs, and travel is not always an option for some folks because it takes such a big chunk out of their day. So we'll do that in May. I did send out those invites. Every board member was CC'd on that email. And we've had several RSVPs. I did give them an RSVP deadline of, oh my gosh, I don't remember, end of April, I want to say, to give them plenty of time to get that link and whatnot. So that's where we're at with that.
And I screwed up and misinterpreted to Dr. Simpson what you just said because he had offered to do the meeting at Anschutz in April. And I said, I think we're going to hold off on that and do it in May because we want to have the in-person one be different than the virtual with the inpatient folks. And I mixed it up. So still in-person hybrid in April. Okay, Dr.
Yes.
Simpson, did I totally screw you up?
I confess that I'm a little confused on the conversation, but if the take home for me is in person in April at Anschutz, then that's great.
Yes.
Okay.
So, Dr. Simpson, if you will just like get me details so that we can
Yeah.
update like the BHA calendar and things like that.
Mhm.
That way we'll have all of that ready to go for when we do the in-person. What
Okay.
was requested is that we would do our usual hour and a half and then an extra half hour to maybe tour the unit if that's available.
Yeah, I wanted to ask what people's like how much time and what people are interested in seeing. Um, and if we have a second, maybe I can just kind of casually pull the
Absolutely.
group real fast. Um, the meeting room we secured is on it's kind of in the Anschutz Health Sciences building, and so it's adjacent to University Hospital. And then our colleagues at Children's were also open to hosting us, and that's a couple buildings away, but we can arrange transportation, like little golf carts or something for folks. But it does take more time.
Mhm.
So the easy thing to do is like an introduction. If we had 30 minutes, we would just walk over to see, like, to look at university. We could see that inpatient unit, the emergency department space. If we had more time, we could travel over to children's. It just sort of depends on what people want to do.
When you say children's, also their inpatient unit, I'm assuming not the medical.
Yeah, it would be yeah, the Pediatric Mental Health Institute and some of the rooms. Like they had some spaces that where like families can stay with youth during this and that,
Oh,
that
wow.
so I don't know. And they also have a new crisis unit that was supported by the BHA, that BHA partnered with. So I guess this just depends. I mean, that's, 30 minutes to get over there and see things. It's probably, if we're gonna go over there, we probably want at least an hour. So cut into the meeting time versus something else. Whatever people want, it's easy for me to set up. I just need to know.
What about maybe a half an hour for university and then for folks who can and would like to stay, do children's at the end? Would that work?
That would be like, hold on. So 11 to 11:30 would be kind of the university, and then 11:30 to 12:30 for people who have time. Is that sort of what you're thinking?
Yeah.
Okay.
That sound good with everybody? And that would be, let me look at the calendar. April 6th? Nope,
13?
13.
13th, April 13th.
Yeah.
Oh.
Okay.
Dr. Simpson, I have a conflicting board meeting that day. Is there any way I could reschedule just a brief tour of university? Because I am very interested in
Yeah.
seeing the facility.
Yeah.
I work
You
with
you're
Amy quite a bit.
not going anywhere as far as I know.
Okay.
So yeah.
All right, I will reach out to you and probably Amy and maybe schedule something around that time.
Okay. Or if you want to come earlier before, well, yeah, I don't know. Let me see. So that might be a lot to ask of our clinical colleagues to host
Well,
multiple.
that might, I have interviews that entire day, so it wouldn't be able to be
Yeah,
that
and
day.
I'm booked beforehand too. So okay.
Okay, thank you. Okay. Let's see, next. Legislative updates.
Give a few of those. So House Bill 261116 was the one where we were discussing aligning emergency commitments with the M1 process. This is one we talked about was kind of a copy paste. I did get a request from our legislators and our legislative team to review what it might look like if we combined them instead of aligning them. So we do have that kind of like in our discussion point of like what are some things we want to focus on, because it does appear that that's coming. It might not pass this year, but it will probably pass next year. So just wanted to let everybody know that they're looking at that change from aligning to combining. House Bill 261063 was secure transport. I think we might have talked about that it already removed all of the 2765 pieces. Samantha! She's got her hand
Yeah,
up.
I just there has officially been an amendment to 1116 that pretty much guts all of the language related to emergency holds. So I think I would assume based on what you said, that means that next year is probably the year. But that bill is not much now. So I'm sure the amendment's on the General Assembly website if anyone wants to look at it.
We will see if we can pull that up here in a little bit. So secure transport gutted everything for 2765. I do believe that both CDPHE and BHA came out in opposition of this bill. And I don't have the details of it. I unfortunately was not able to listen to that testimony. I'll look to Samantha to see if she has that or if anybody else has it.
Which one did you say? 1063?
Yes. So this is the one that would bring secure transport licensing under CDPHE. Joy, do you have any of that testimony or details? She's looking for it.
CDHS has largely stayed out of this one since our sister agencies have so much to say about it. So I actually haven't been following as closely, except the strike below.
Perfect. And then competency is the last one. It's still not introduced. The updated timeline is end of this month for introduction with amendments. I did get a little chat from our legislative person just like 5 minutes ago saying that they're going to be looking at sending us a fiscal note for review. So to be determined, we will continue to provide updates as we have them.
We also got fiscal review. I think they're trying to get fiscal review done before they introduce it.
Yeah, my understanding is they'll actually introduce fiscal before we even get our amendments finished. So we will see what that looks like. Okay, I'm going to open a document really quick so that I can take notes while we talk about, while we talk about combining the EC and the M1 process.
While you do that, this is Michelle. Is there anyone on this call? So with the 1116 ECM1 legislation, is there anyone on this call who was part of kind of initiating this with Rep. Ryan? I know that it was, I was told Summit Stone had a big part in this. Anyone else know anything about that?
I'm sorry, which bill did you say?
1116, the one that Joy commented on and the one that we said we should keep an eye on. It probably won't go through this year, but next year. I've been tasked by COPA to do a little bit of research on something, and I'm just wondering if anyone on this call was part of the initiation of this crafting of the legislation with Rep. Ryden.
I wasn't part of it, but I can talk. I know the Summit Stone people pretty well. I can try to get some information.
Okay.
And I wasn't at the last meeting, but it seems like you guys didn't discuss amongst this group if you thought combining the two was a good idea. I guess that's what we're going to discuss now.
Yeah, I'll reach out to you offline because I have just some specific questions. So I'll reach out to you and email you, and we can chat at a different time if you have a moment.
Okay.
Thanks.
And then so the other bill we're looking into why CDPHE doesn't want to do the transport. Is that correct?
Yes. Joy, were you able to find any of those notes?
You know, I know that there was opposed just because of how, if I'm remembering correctly, just that there was so much discussion when this came through about the local control and wanting to come back, to bring it back through up to the state. It would just take more of a process, they believe. So it passed nonetheless, and it's going to appropriations. So it's going to happen, regardless of, what opposition was expressed.
So did this group actually discuss that bill last time? I'm curious also to hear what this group thinks about that.
We started to talk about it. And I know Michelle had a lot of thoughts because this kind of goes right hand in hand with the stuff that she does on a regular basis. There was a lot of, I think this will be good. We'll have a general state level oversight. We won't have to have this piecemealed, different rules and regs based on county. So there was some positive input. I'm not remembering any negative. There was a question of why didn't BHA take this? And we discussed that briefly, but
yeah, what kicked off the conversation last time was I said, isn't there a list on how many secure transport agencies there are in the state? And I don't remember who responded, but they said, that's the point. Everything's held at the county level. There is no way to know at a state level what exists. So that's what launched the conversation of some of the positives.
Joy, Joy, could you clarify a little bit more about what the objection was? So you're saying that they wanted more local control, and it sounds like Michelle is saying that that's not a great thing because there's so many, and it is a mess.
Right. I think years back when behavioral health secure transport first, became a thing, there's always been a push-pull, about what is state run, what is local control. And so I think that there's been so much sentiment over time that communities know what's best in their own communities, and so they need to attend to that. And so that was the initial sentiment coming through, is like local control. Now we've seen that come through. We've seen how there's just the hurdles about, just crossing county lines and things to effect that we've all discussed. And so I think it was just, there was a sentiment early on in behavioral health secure transport that this is, licensed or at least certified through the local counties. And that's, I don't think we ever want to, I don't know, this is just kind of my naive opinion, but we just are a little reluctant to take control at the state level from the local level. And so I think that may be part of the sentiment behind the reluctance to be all behind it. But like I said, it passed, and it's going to be moving forward. So hopefully we will get to see some of that consistency come through and a list of active providers on a more consistent basis, like the legislation hopes.
I wonder if there will be a process where they elicit local input, because that's one of the positives I hear in the local communities, that the county folks, so some of these agencies have reputations, and locally people know those reputations, but at the state level they don't. And so I wonder if there will be a process to elicit local input on process, service provision, positives and negatives of service use, things like that.
Any other questions, concerns around the legislative updates? So the next thing we have on our agenda is what to focus on in the next year. And the only one we have listed below is because we kind of know it's coming, is that combining of EC and M1s. The question I would have for this group would be, instead of just looking at EC and M1, do we also want to look at ICs combining with certifications?
I guess I don't really know that much about EC, IC, and I know that the EC is 5 days, right? Versus the M1, which is 3. Is that still accurate?
Yes.
So then what's the next step from EC? Is there already a process and it's called involuntary commitment for substance use treatment? And then how long is that effective?
Yes. And I do have Taylor with us today. Taylor is our jurisprudence training specialist, but she does a lot of EC, IC, M1 short-term cert overlap trainings with our EC team. I'm going to let her talk because I am not an expert in this field.
Okay.
So for that EC process, I'm not that ECIC trainer. So again, this is my understanding and kind of what I gathered from their trainings. That EC is kind of that first up to 5-day hold, essentially. They can only be authorized by withdrawal management. So like our community partners and things right now can't technically write it and authorize it. They have to wait for that withdrawal management. While somebody is on that EC, if they get a petition for the IC process, it can extend the EC for up to 10 days so that they can get like paperwork and things like that filed with the court, but they have to get the paperwork filed within that first 5-day period of the EC in order to extend it for that additional up to 10 days. Then they go through the court process, and if the court authorizes it, they can move to an IC, which is, depending on if the person contests or doesn't contest, 90 to 180 days, essentially. Did that answer the question?
Yeah. So you could skip that extra 10-day process if withdrawal management sees them within that first 5 days.
Yes, but they still have to wait for the court order for the IC. So they're going to stay in withdrawal management until the court orders that involuntary commitment, which is the longer term substance use commitment, similar to our short-term certifications.
Okay. So unlike an STC and an ESTC, unless meds are involved, you have to have the court order in order to be involuntary committed, versus a short-term cert. As long as a professional person does it, you don't necessarily get a court order.
Yep, correct. They have this, it's kind of this whole process. It's a little bit confusing to explain without their presentation, but they get the EC and then they get the IC petition. And then with that IC petition, they have to get a physician certificate who's also supporting the IC. And then they can send that to the courts. And then the courts go through all of that. They have the ability to contest it and things like that. And the courts have to do all of that process before they can order that IC.
And I did quickly chat Brooke, our ECIC trainer, and she's been amazing and jumped right on in to help us further.
Brooke, amazing.
Yay.
Good morning. I caught the tail end of that, but I missed the question. So how may I be of assistance this morning?
I think we're all pretty familiar with the 2765 process. So we're just trying to get, I guess, a better grasp on the ECIC process and how it is similar and dissimilar to 2765.
Okay. I'm guessing it's a little bit backwards from the 2765 statutes, just as we have a lot of stuff we do up front before it can go to the court process of it. I know Taylor already spoke a bit about it, but the first step of it is they have to get placed on that emergency commitment hold, which is up to a 5-day hold for individuals that are intoxicated or incapacitated. And that hold can only be authorized by a licensed withdrawal management facility. And that licensed withdrawal management facility has to have the correct license and endorsement in order to place that hold. Once they're on that, anyone 18 years or older can submit a written involuntary commitment application for someone that they're concerned about. They have to have firsthand knowledge of that individual's substance use, because of that substance use, they're a danger to themselves or others. And then their refusal to get voluntary treatment. Once that application is received, BHA, so my team, will work with that withdrawal management facility, or if they happen to be in a hospital, we'll try and coordinate with the hospital team to get a physician with the credentials MD or DO. That's required by statute. The physician then has to evaluate that individual to determine if they believe the person has a substance use disorder and would benefit from the process. As long as we have a supportive physician certificate, then our office can loop in the county attorney's office. And we can file either in the county that that person is physically present in or the county that they reside in. So we'll loop in that attorney's office and they'll draft a petition for involuntary commitment. And then that's what they will use to file with the courts to open up a case. Once they've filed that with the courts, it extends that 5-day hold for an additional 10 business days. And then within those 10 business days, the courts will schedule a hearing. Our office is going to do some behind the scenes work within those 10 business days. We work with our withdrawal managements to get assessments completed, both an ASAM, which is an American Society of Addiction Medicine assessment, and a biopsychosocial. We then, our team at BHA meets with the withdrawal management staff, and we loop in our BOSOs, which are our behavioral health administrative service organizations. So either Signal or Rocky as our care coordinators, we loop them in, and we have a meeting to discuss an appropriate treatment plan for that individual. And then our office at BHA will draft what's called a recommendation for placement. We submit that to the attorneys, and they'll use that to draft a stipulation, which is just a kind of like a written agreement for that individual to say, yes, I'll just do what you're telling me I need to do. So they, through this process, depending on the county, because every county does things a little bit different, but they are given a court-appointed attorney. And so that court-appointed attorney will meet with that individual, explain to them, like, hey, this is what BHA wants you to do. This is the treatment plan. You can either sign a stipulation for 90 days by statute, or you can go and talk to the judge. I will say most of our clients 90% of them will sign that stipulation because they want to get out of withdrawal management, because I don't know of those in here that have been to a withdrawal management, they're not meant for long-term stays. So most of the individuals just want to get going. But if they don't want to sign that, that is their right. And we will go to a contested court hearing. At that court hearing, the BHA will have a representative there to testify. The petitioner will have to testify. The respondent, that's the person being placed on this, will have to testify. And then they may or may not call the doctor that did the physician certificate to testify. It just depends on the county. Certain counties like Larimer require the physician to be there. If they don't come, they'll throw out the case. But our office kind of knows these nuances and manages that. And then so at court, the judge can either impose that 90-day court order, or they can dismiss the case. If they dismiss the case, the individual's moved to voluntary status and immediately released. If they're ordered, then we move forward with the treatment plan as we had planned on. I feel like I talked a lot. Is there questions or anything other specifics that I can help answer?
Is there ever a situation where between the 5 plus the 10 days for the EC where there isn't placement? Like
So
no beds available?
we run into not having placement mostly when if we start the process when they're in a hospital, and then we can't find a withdrawal management to accept them. Mostly we find difficulty when there's severe medical acuity, because our withdrawal managements can't provide, like, for instance, we had one that we just had to decide not to move forward on because no withdrawal management could take them because they had an open wound, and none of our withdrawal management facilities would be able to provide wound care. And so, yeah, so we do run into that, but if they're in a withdrawal management, when we start this process, they will stay at that withdrawal management, and that withdrawal management will not discharge them while we're pending this process. Even after we go through this process, they stay in that withdrawal management until we have a bed date.
Got it.
The key that we always run into, though, is they don't stay there and they're not locked. And that becomes the biggest difference between one of the biggest differences between the system of 2765 and the system, or M1s, and the system of ECs, is that across the state, if you're on an M1 and you go into a 2765 facility, you can't leave. It's locked. None of the withdrawal management centers are locked. And so we run into, yes, they're not going to discharge them, but we end up having to go find them because they leave.
Yes, that is. So when I give my presentation at the end of it, we talk about some of the limitations throughout this process. And that is unfortunately one of the biggest limitations that we run into, both with withdrawal managements and then on the other end of things with our treatment providers as well, because there are no locked substance use disorder facilities. So we can go through this process, we can place them in treatment. They can just get up and walk out. They are on a civil court order. There could be consequences to violating that. They could be held in contempt. But it also then we bring in all these other entities that BHA doesn't have oversight over. We can't require the courts to issue pickup orders. We can't, if the courts will grant us a pickup order, we can't require the sheriff's office go out and enact it. So we have to get all these entities be willing to like play with us. And that's not always feasible. And so we do, I will say, when I do my trainings on this statute was written in 1974 and has had very, very minimal statute updates over the years. There have been like three different bills that have passed, and they've minimally changed. Right. So, and these statutes are like 1 page and 1.5 page long. And then you have 2765 statutes, which are like, I think I said 20 pages, and Taylor laughed at me the other day.
Oh, it's like 280 something.
Yeah, I know. She was like, no, Brooke, it's way more than that. And I was like, oh.
Well, and I will say I was the one that kind of asked Jess and Jen if we could keep this on the agenda, because I really love the makeup of this group. I think we come from so many different areas within the continuum of mental health and outside of. And the very core of just this one little piece, locked facilities versus not locked facilities, how do you combine these two processes? Because you have to change the entire system. Plus, with the ASAM changes, some of the withdrawal management centers are going to go away. So we're going to have fewer of those to work with. And so I've got some lots of experience and lots of opinions and lots of conversations that I sit around the tables locally and listen to. But I genuinely would love this group to have a really robust conversation about this, because this is not going to go away. And I think if we can have really good conversations with some solid thoughts and recommendations and ways that we think this could or couldn't work. The biggest thing that bothered me about some of the conversations I was part of last year was, at the end of the day, as we were talking about something, comments were made that said, literally, we don't have time to discuss that. We just need to push this through. And that is, to me, irresponsible, unethical, unprofessional. These are laws you're trying to put into play. And so I think this group has some really amazing people at the table, and we have time on our side now until next year to really thoughtfully talk through some of this. So if you don't like this topic, it's my fault, because I'm the one who pushed it on.
Any other conversations around it? I mean, what are people's thoughts about combining? It seems like, while similar, there are some enormous differences.
Yeah, I mean, I think like Michelle, I have so many thoughts on, 2781 and this process generally. And I also don't know if we have any like public, like patients or family members, because that's such an important voice in this process, particularly. I mean, I guess like just a couple quick observations as a psychiatrist who's worked in the ED, who's done lots of ECs, who's petitioned for ICs. I think one is that it's kind of a quirky process, for not like legally, but clinically, because you're oftentimes talking with patients who are, I mean, they're not disorganized, delirious. They really don't want to be involuntarily petitioned. And if that results in these conversations that can be really dangerous at the point of care, where you're telling someone who's got a severe use disorder, oh, we're going to emergently commit you, and people get really agitated. May end up in facilities that can't accommodate them. I think there are a lot of games that get played on referral to withdrawal management. Like, is there an open wound? Can we accommodate that? The criteria for what constitutes medical or not. I think is very opaque. And then once you get to this long involuntary petition process, it's not clear to me that a lot of these facilities, even if endorsed, can handle kind of the clinical picture that's coming in. And so all of that is to say that I don't know how well the current statute kind of reflects clinically what we see in this era where patients are getting it, EC with severe opioid, cannabis, methamphetamine related disorders. Um, I think the other thing that happens, and then I'll stop, is that there's a huge disconnect between the public perception of what this can accomplish and what infrastructure is there. So, I mean, we get a lot of families who, see this as kind of like, it'll solve everything, or I don't know, the BHA is there, but like there's, I see comments in the media, I hear from family members, I see politicians talking about, well, this is a great process for solving all kinds of substance related problems. And I think on paper, it makes a lot more sense than it does in practice, based on the kind of infrastructure that underlies the law. So I, I mean, all that is to say that's just my perspective, and other people have seen different parts of it, and there's a lot of localisms too. But I don't think, I mean, I think the idea of simply merging the two is way more complicated in practice.
That makes sense.
Yeah, Scott, I completely agree with that.
I think we need to take a look at the dynamics here. There's a dichotomy here of where you're looking at the infrastructure of how it looks or how it reads on paper, and then what the infrastructure looks from the facilities themselves, because it changes the dynamics from voluntary, involuntary, the triad of medical, behavioral, and security. It changes the infrastructure of the facility itself. So as long as there's some back end accommodations, maybe even comes down to money to where facilities can then change to support their infrastructure to be able to meet the requirements, then I think that's across the board. But for us to push it from I guess the paper perspective without considering the back end of that, the infrastructure of these facilities, we're going to end up, I think, hurting it in the long run.
And I will say, Dan, I just, want to briefly comment that I think that like the network of withdrawal management programs and some of the addiction resources we have are a relative strength of the system. When I talk with people outside Colorado, like the idea that we've got, even dozens of withdrawal management beds in the metro area, whether it's CARES or East Metro, now Aurora Mental Health, I think is a strength. So we also just want to be thoughtful not to break something that has some relative strength for our region.
I'm sure we discussed this in the past, but does anybody remember where this conversation originated, combining the two?
I mean, that was before my time.
Yeah, it's been quite a while. I remember the conversation about combining the M1 EC. I just don't remember what started the conversation.
Do you mind if I jump in? This is Frank with CBHC. I'm not a member of the committee, but got some insight into this.
Yeah, please.
Hi, everybody. Frank Cornelia, CBHC, represent CSNPs, and we were a part of an early conversation or group of conversations with Rep. Ryden on 11/16, and I think the core idea was really around the alignment of the M1 and EC. So not doing the bigger thing, understanding that that would be a longer conversation. I even thought this was going to be more of a conversation before it became a bill very quickly, and then it included other things too, which I also think was part of the problem. There were some drafting decisions, I think, outside of my purview, that definitely needed some cleanup. So as we talked about this, and there were other folks involved in this too. Ryan Templeton was a part of all those meetings. Denver Health was there as well. I think it's, as you think about where we're heading as a state with the ASAM alignment and the rules and having integrated, not just, I think both federally having looking at integrated funding and at the state level with consolidation of different line items and with rules, I think you start to think, okay, now we're going to have to align our processes, with regs and financing. So that's just where the system appears to be going. And I don't even know if like the total combination conversation is about necessarily having one process that fits all conditions, but maybe having it under the same title and having different pieces of it, having and creating some flexibility for different conditions, obviously, but I think that's the spirit with which it came from. And I know, Ryan's not here, but this has been a long standing conversation. There was a bill draft, at least put on bill paper. I don't even think it ever got introduced, but to combine these things, and as you can imagine, it picked up a lot of heat. This goes back like 2013, 2014 is what I'm talking about. Um, I don't know if you have questions for me, but happy to answer what I know. And um, so.
Think the fact that this has been a discussion for 13 years now probably speaks volumes.
Well, is there a way that, I think, obviously there's some concerns. I think Scott articulated really well, but also, a lot of what you're saying, Frank, makes sense. That we start to align these processes. I wonder if there's a way we can kind of all put our heads together to, especially if this is looking like next year is really when there's going to be a push to do it. See what would make the most sense. You guys have already done so much work, so we don't want to undo that, but we have, I guess a lot of questions. So
Yeah, for sure. I think it definitely warrants the conversation with this group in particular, and not to mention maybe a broader conversation. But and that's really just to reiterate, like it was meant, 1116, or even the conversation was meant to be a smaller bite of, the bigger elephant, not a total, integration, but just aligning the emergency process. So.
Frank,
Especially
can
as you
I
think
ask?
about the
Oh, sorry.
health, crisis center regulations. So sorry, Scott.
Frank, what is from CBHC's perspective, what is the problem you all are hoping to solve with kind of these reforms?
Yeah, I think it is thinking about trying to, I think, what am I trying? Like, you have these combined regulations under a behavioral health crisis center, that you get some economies maybe of scale with aligned processes, for workforce and some of the professionals involved, and some of the admin, related to it. Not to mention, I think as we got into the details of this, like some of the language around the EC and IC statutes doesn't necessarily match with the way that we regulate BHEs anymore. And I think that's even going to continue to change with the ASAM alignment and rules. Thinking about the terminology around the administrator, I know that one tripped us up quite a bit. So.
And the proposed crisis rules are still in flux, right? Like we just got another revision posted on the BHA website at the end of last week. So yeah, it's going to be one of those, which is coming first, the statute or the rules?
Can you put
So we
that
have
link in the
to.
chat, Jess, that was just posted last week on the BHA website? Would you mind, please?
Laws and rules?
Yeah, whatever you just said was just posted.
Yes, I can do that.
Thank you.
Well, I wasn't aware of the history of how long it's been since this has been updated, but definitely sounds like some updating is needed, and this
Well, it
may be
wasn't, I mean,
yeah.
yeah, not updated, but it was raised as a possibility. I think following the crisis bill came first, and then this conversation around combining, and it got shot out of the water pretty quickly. Just part of the decisions. I think one of the like it tried to do a blanket 5-day hold instead of a 72-hour hold, and then that just you know and then it brings out there's some natural differences in populations related to either condition, and so I think individuals that identified with lived experience with mental health specifically, came out strongly against a proposal like that. So I, it didn't, it, I mean, like I said, I don't even think the bill idea got put on paper, I think by OBH at the time and didn't go anywhere quickly because of some of the strong reactions to it.
I mean, maybe given the purview of this group, I mean, this may be something we really want to look into tackling in the future because, well, even now, because so much has changed and how kind of it would make sense to align it. And Frank, I don't know if you were on when it came up that maybe there was some push to combine ICs with certs. Has that discussion come up at all? No. Okay.
I mean, not other than like the larger alignment conversation, is that something that would be helpful? But it was not something that we contemplated or this small group contemplated. It was like, no, that needs a bigger conversation,
Yeah.
We weren't that grandiose about it.
Hi, I'm one of those people actually who objected to this because my daughter she had severe mental illness, and a lot of the things we ran into is that it was very easy to get someone into a substance abuse bed. It was really hard to get someone into a mental health bed. So I think sometimes combining these things makes it so that in Colorado, I think it is correct that it does have a pretty decent system for substance use disorder, but there is a problem with help for severe mental illness. And so the objection I think that a lot of people from the groups that I'm in are having issues with is that when you combine these, you end up ignoring the mental health condition in favor of the substance use. Literally, sometimes I said, well, maybe we could just say that she has a substance abuse. And that's an issue. So the issue with combining them, I think from an emergency room, that makes sense. Yeah, of course. You want to make sure that the system is the same, but the problem is that then sometimes ignores some pretty serious conditions.
You bring up such a great point. It is so good. And I think that's where you get this population of professionals in the mental health field that believe very strongly against assessing folks that are intoxicated because you don't see the true God-given chemicals of what's happening versus the group that says you have to work crisis in the moment and you have to make an assessment. The problem is, we get those folks who sober up in the morning and then they find they're in a locked facility 4 hours from home and they go, what happened? Well, you said you were going to kill yourself. I fought with my boyfriend. I was drunk. I didn't mean to say that. But now they've taken up a bed that we have a really high need mental health patient that needs this. This is such a huge topic. And Dr. Rice, I totally agree with you. I think this is a robust conversation we could have. And again, I go back to the people sitting at this table come from such different areas that I think we could have some really good discussion and come up with the pros and cons and put them on paper. And like Jess wrote in the chat, this would be a really great thing for us to use as a recommendation this year.
Yeah, I would just love to echo Kelly's point because my experience is that a lot, I mean, I don't even want to say most, or I don't know, but there are a fair number of individuals, right, who are in involuntary petition processes, they're in addiction treatment program, and they certainly have a use disorder and an issue, but it's like what really the reason that they're kind of staying in those systems is because they have severe catastrophic social situations, they're socially disconnected, they have other impairments, maybe related to psychotic disorder, SPMI. And it's like this is a safe, good, supportive place for them where they can consistently access treatment. And I think in some ways it's like there are deficiencies elsewhere in the system that drive patients to like these spaces. And so it's just another peculiarity of the system.
Again, though, I think when that happens, what you end up with is people who have, my daughter had schizophrenia. When you have someone who has a psychotic disorder and they're put in a substance use, the substance use is what's being treated. So they're in a substance use bed. That's what gets treated instead of the psychotic disorder that's causing the substance abuse. So I think it's kind of like the combining of the two can cause some problems that are are unintentional, I'm sure, but they're pretty significant.
Yeah, and I would extend that to include like concurrent medical illnesses. I mean, we know that, persons who are struggling with severe psychotic disorders, right, have a life expectancy more than a decade shorter than the rest of the population. They're not getting access to preventive services, medical care. And so how do we make sure that individuals who are in these systems, regardless of why, right, are getting access to that treatment? And so, yeah, it's just an example of the problems of like siloing all these services and fields.
Well, in the legislators, what I hear them say around certain tables is this is done in other states. This is possible. We looked at these states and they actually have one hold, whether it's substance use or mental health. And while that is not wrong, one of the things I love most about my career at this moment is I get on a plane twice a month and fly to different states and I train the frontline boots on the ground people. And I am hearing them talk about why this doesn't work. So even though other states have things in place, we don't necessarily just want to, take the wheel someone else is using without creating our own. Why create another wheel if something exists? But you can't just talk to legislators who pushed it forward. You need to talk to the boots on the ground people telling you why it's not working. So yes, they're going to pull from other states that actually do this, and that's not the answer either.
Yeah, I hear that, Michelle. I don't know if we talk. I mean, I was a part of, 3 or 4 different meetings with Rep Bryden and this smaller group, and didn't have any other states raised. It was really about looking at the combined rules. That is, this is a very significant rewrite that overlays ASAM over top all of the treatment rules in Colorado, and the feds are moving to put the mental health and SUD money together. So it's really like, as you think about the regs and the money coming together, what does that mean for, these processes that we're talking about? So and I hear what Kelly and Dr. Simpson are saying. We're swinging from having everything being separate to this push towards integration, with mental health and SUD, and there are still reasons why there are separate conditions with, needing separate assessment and treatment and placement options as well. So you got to find a balance in it.
feel like this is something that's going to be discussed for, I mean, it's already been close to 2 decades, maybe another 1 to 2 decades.
Not with this group. We can move faster than that.
We can solve the problems.
Yeah.
I think it's
Well, that's
because
why I
at
said,
the
earlier,
core,
just like, is there a way that we could, contemplate as a state, with a larger conversation that this happens under one statute doesn't mean full integration where it's all behavioral health general, that there are considerations, clinical and medical judgment, around assessment, treatment recommendations, and placement recommendations that take these different things into account and create, leave flexibility so that we're not favoring one or the over the other.
yeah. Okay.
So safe to say, continue focusing on in the next year.
Safe to say. But I go back to look at everyone at this table. We come from such different and varied places, and we see things that are really important to all put on the table. So I love this.
Yeah, thanks for sharing all that, Frank. That was really helpful.
Yeah, sorry to jump in halfway. I was like, wait,
no, we needed you to jump in. Thank you.
Yeah. I don't know I don't know if I missed if you talked about what was left of the bill after, this amendment's gonna, gut most of it, and it's gonna land on like, clarification around 72-hour hold. I don't know if that would be still the thing to take a look at if you haven't yet, and give Rep Ryden some feedback on. But
Haven't seen any of the amendments. Frank, do you have a copy of it?
yeah, I could probably throw it in the chat. But
Thank you.
it like I said, it peels away almost everything other than some clarification around this 72-hour timeline. And I should clarify too. I don't think it's not M1 timeline. It's 72 hours for follow-up. So
Yeah, I had heard there was a lot of opposition on the floor, and I was just so curious what everybody's different takes on what this what it was. It's the 72-hour follow-up. They also stuck in there something about the licensing being done with your fire code inspections. That got stuck in here.
yeah, as I look for this amendment, that was the thing I was trying to mention with there were drafting decisions made that were outside my awareness. Like, actually think BHA, I don't know if you all had, I recall some conversations with Erica around the fire code issue, and then there was, one around courts being able to order treatment, and that one also was picking up some conversation that I was not privy to,
And the grave
definitely,
disability definition.
yeah,
They changed the grave disability definition, so now we'd have two. And then the other one was they want to do away with withdrawal management centers being the final say, and that they took the intervening professional language from 2765 and basically said any intervening professional could approve and authorize an EC, which I think sparks lots of conversation from all different places. Thanks for sticking that in the chat.
Any other last minute comments on this or anything else we should focus on for the next year?
Which is one and Michelle, you might remember 1116. This was the one that had that language about taking people to jail too, right?
Yeah,
Under
in the top, it talks about
Yeah.
once they are picked up by law enforcement, they can be taken to jail. But then later, it was almost like a cut and paste of something from
Yeah.
2765 where it said they cannot go to jail. But then
Okay.
later it said they could go to jail. So it was really confusing. But yes, it did say they could be transported
Yeah.
to jail.
Yeah, and the language was weird. It was like you can go to jail, but there shouldn't be a record of arrest. I mean, I guess I just want to chime in so that because I don't want to speak for anyone else, but I at least would want to be on the record that I don't think that people on mental health holds should be taken to jail or ECs should be
Well,
taken to jail.
No, and that was
that
taken out of
that's
2765 on
Yeah.
purpose, right? It was
Just got rid
removed.
of those. Yeah, exactly.
Yep, we ran that in 2017 and removed that option in the mental health, and it continues to exist on the substance use disorder side. And we pushed for that to be included in 2017, and people said, one bite at a time. So that was, I think there was maybe an awkward attempt in this bill to address it, but leave it. I mean, eventually it should come out, this option. If, we should have the right treatment placements in place or transport options in place so that jail is not an option for people who haven't committed a crime. And the amendment I just put in there, it looks short, but it's significant because it cuts or strikes a bunch of sections and pages of the bill.
Anything else to add? Quiet group after all that.
I was just trying to do the copy, or not the copy paste, the comparison between like all of the notes of here's what we're amending to like what are we keeping. Yeah, it only keeps 2765 and 2750.
So one of the issues with this is when it says you're not allowed to take anyone on a hold to jail, and there are no facilities to take them to. I mean, that's, I think, something that we need to discuss in terms of what are the other options. So you fill up emergency rooms. What happens? So this is a concern, and I know it's a much bigger issue than this group. I get that, but it is something when you're fighting for a legislation that says, okay, we can only take people to hospitals, and yet sometimes people, and in order to even get care, you've got to be pretty severe. And then there's no hospitals to take them to. So I mean, this is a much bigger issue here that like, so a lot of times these things are coming about because of broken pieces of the system. Because no one would be taking someone on a hold to a jail if there was another option.
Well, I mean, I think so much, and this is what this group has to be really careful about. I mean, I think there are definitely times when involuntary treatment for mental health or
Karen, you froze up there. The challenge that we had in 2017 that would continue to exist is good luck finding data from jails about any type of holds related to this. It was impossible to find and calculate for the mental health side, and suspect it would be just as difficult on the SUD side. And Kelly, your point is well taken. I totally agree. And that was, I think there was some, one of the reasons that that option came with, the like $9 million to expand the crisis system, to try to give communities alternatives, including transportation alternatives. And then, on the reverse side, like, yes, you need the appropriate facility, and you also don't want people picking up charges, especially assault against law enforcement, which comes with some pretty severe consequences.
We've got about 15 minutes left. Were there any other topics that we want this group to focus on for the next year?
Jessica, I mean, not to, 15 minutes left, but has this group talked about the pathways bill? And does everybody know that it's coming?
Yeah, we've talked about it. We've been waiting for it to be public facing,
Right.
really, with all the amendments, which is supposed to be sometime at the end of this month. So I suspect we'll spend a lot of time talking about it next meeting.
All right. Any other last minute questions, comments? Discussions about in-person next month? Just to reiterate, Anschutz campus with an additional possible tour at Children's Hospital.
Question, Jen, this is Ruben Farnsworth. So like for me, for a 9:30 meeting, I come over the night before because it's such a long drive. Is there reimbursement with these things for hotel and whatnot, or how's that work?
Joy, can you prioritize reaching out to Ryan Templeton and getting an answer on this? This has been several months now. Thank you.
We'll get back to you, Ruben. We've been asking about
Yeah,
that
no, I
process.
knew there were some questions out there. I know a lot of other state stuff. There's reimbursement for room and mileage and things, but
Yeah.
all right, thank you.
Dr. Simpson, when we're looking at rooms, is there a way for us to get a room so that we could do a hybrid option for those that aren't able to travel?
Yeah, the room we got has all the hybrid whatnot set up, and it works pretty well. And I think we have, I don't know how many in person. We'll find out with the RSVPs, but I think that room accommodates 20 comfortably, and if we have more, we can move up. So
Okay, perfect. And I continue to check our public question thing that Caitlin made for us forever ago. No responses in it still.
That seems, I mean, we used to get several every month. So is it possible to like publish it somewhere else? I don't know. It's on our website, right?
It's on the website, and it's specific to the Mental Health Advisory Board.
So
I mean,
where is it buried on the website? So that website is not particularly user friendly. Because I don't think I know where it is.
so when you go to BHA, I believe it's under individuals and families. Hold on. I always just search MHAB when I get to the website. And then it brings up our Mental Health Advisory Board for Service Standards and Regulations. It is at the bottom with resources. Where is it? Member.
Maybe move that up to the top.
Well, I don't have access to the website, but we can, yeah, I'm trying to find where that actually lives. We also just lost, naturally, our website person. So I'll have to figure out, because I know there's a link for it, and it's not easily accessible. Like, it's not easy to find. So we'll look into that and see what we can do once we get our website person hired.
There were some other things on the website also. I know the dates for the meetings had not been updated last time I checked. I don't know if that's been done since.
They're
But
updated as of today.
okay, good. But there are other things that like I'll post those there if I see them. But every once in a while I'll see things on the website that are just not valid. They're not
Like,
updated.
I would say anytime you want to make a list and let us know, we can absolutely pass it along. Because we don't know what we don't know. We're not usually on the website. Yeah, even like the members contact list is like from fiscal year 24-25.
Mm-hmm. And these so the recordings of these meetings also are supposed to be on there. And I think I didn't check this month, but a lot of times it takes them a long time to get on there. So if you miss it, like you can't catch up with this meeting for another 3 months, which is problematic.
And you're going to the YouTube playlist?
Yep. But that might have changed. Like I said, I didn't check it last month. I know I checked it the month before because I wanted to hear something from a little while ago and could not find it.
All right, I'll dig into it as much as I have time for.
I will say, so I submit the recordings after we finalize the meeting, either same day or same week. However, it then has to go through processing with BHA's communications team, and they do take a while, and that's just unfortunately how that process is because they have to publicly approve everything.
They have to make sure we didn't say anything off color.
No, I mean, they're not censoring anything.
I'm
I
totally
was like, okay,
kidding.
I'll stop talking.
I'm
Fine.
totally kidding. I'm totally kidding.
I mean, if they were censoring, Lord knows I would be in way more trouble than what I am. So, shall we call it?
Did I miss? I'm sorry, I had to step out. My house is being worked on. Did we approve the minutes? I feel like we just went through, but we didn't approve them.
You're right. Thank you. I didn't hear anybody have any adjustments. So do we have a motion?
I'll make a motion to approve.
Thank you,
Thank you
Michelle.
for making my change, Jess.
You're welcome.
I'll second. Thank you. That would not have been good. We would have had to redo that. Good catch. All right. I think we can go ahead and adjourn 10 minutes early. Thanks,
And then
everybody.
we decided the April meeting was at Anschutz. Are you going to send location, address, room, all that fun jazz? Okay. Fantastic. Everyone have a great week.
You too.
Bye.
Bye.